If this weren't the first webinar like this that we've had, I'd say that we have a record-breaking number of registrants. So it will take a while to get everybody on the webinar. We're just going to give people a few more minutes to all assemble, and then we'll get started. We're really looking forward to this session with you, and really appreciate the engagement that we've had by everyone interested in this topic and enthusiastic about being here. For anyone who's just joining, there's not a sound problem. We're just waiting for everyone to assemble prior to starting. We'll start in just a few minutes. Thank you so much for joining us. All right, let's get started. I'm Nancy Baxter. I'm the head of the school, the Melbourne School of Population and Global Health. And I'd really very much like to welcome all of you here to the webinar tonight. We're going to be discussing personalizing care at the population level, the opportunity for social prescribing. I'm really so pleased that there was so much enthusiasm about this talk, and welcome you all. First, I would like to acknowledge that I am on the lands of the Wurundjeri people, who have been custodians of the lands and waterways of this region in Australia for thousands of years. And I pay respects to their elders, past, present, and emerging. And I'm sure you pay respect to the custodians of the lands that you are on now, if you are not in Melbourne. And before I get further into it, I want to be sure that I thank our fantastic students in the MPH who have really conceived, organized, advertised, and made this event a possibility. So very much thank you, and specifically to Sharon Slade and Zainab Karashi, who have really moved this forward. So an amazing effort, and it's really wonderful that we're all together. And it just shows how really fantastic our public health students are and how the future of public health in Australia is on very solid footing. So thank you very much. So social prescribing. Well, you know, I'm a colorectal surgeon, and you know, I'm not practicing in Australia, but certainly my last day of practice was about a week before I moved here in January. And you know, not infrequently, and even though it's a surgical practice, not infrequently, you'd see a patient where what they needed wasn't something that I was going to be able to write a prescription for them to fill at a pharmacy. What they needed was social engagement. They needed more activities in their communities. And I think for a long time, many clinicians have felt that they just weren't able to provide what their patients needed. We just didn't have in our toolkit the things that our patients actually needed. And so there are many community organizations and a lot of things going on in the community that would be much better than any pill we could prescribe for them. But how we connected patients to those community resources was just, the dots were not connected. And so this is the beauty and the promise of social prescribing, the ability to improve people's well-being and health and potentially decrease healthcare costs and use of the healthcare system, but most importantly, just to improve the lives and well-being of our patients. So I think it's something with tremendous potential, and it's really fantastic to see how it's becoming accepted and widespread. So we're very fortunate to have with us today James Sanderson. So James Sanderson is the Director of Personalised Care at the NHS in England and the NHS Improvement. And here he leads a range of programs to try to support people to have more choice and control over their health and well-being. He's a social prescribing expert. He's the CEO of the National Academy for Social Prescribing. And there he leads the creation of these partnerships that allow the arts, health, sports, leisure, and the natural environment to be available for patients to promote their health and their well-being. So he's going to talk to us about the experience, his experience, his expertise, and what the NHS is doing. So that's really going to be tremendous. That's going to be followed by an interactive panel by the Melbourne School of Population and Global Health's own Rob Moody. So Rob is the deputy head of the school, well-known physician in Australia. He was the CEO of Vic Health from 1998 to 2007, and he chaired the National Preventive Health Task Force from 2008 to 2011. He advises the WHO on the prevention of non-communicable diseases and has been really an indispensable asset, shall we say, in my start as the head of school. Our panel, I'll just briefly say who is making up our panel, and Rob will introduce them in more detail. We have Charlotte Hespy, Sandra DeMaio, Tracy Johnson, Megan Cicciarelli, and Leanne Wells. So I'd also like to say that this really builds on the absolutely fantastic work in this area by the Consumers Health Forum of Australia. And I know many of you may have been on their webinar in Australia. So it's really fantastic to see so many groups aligning to try to implement this very exciting and I think very important adjunct to the ability of clinicians to improve the health and well-being of their patients. So we will be using the hashtag social prescribing. So please tweet, use it on Facebook or Instagram, or if someone wants to do a TikTok, they can go ahead. But use the hashtag social prescribing so we can all share everyone's insight. And with that, I will give it over to James to hear about what's happening in the NHS. Thank you.
Thank you very much, Nancy, and very, very good morning from England and good evening to you over there in Melbourne. It's an absolute pleasure and privilege to be speaking to you all today about our experiences of social prescribing and personalised care here in England. It was lovely to hear Nancy paying respects to the custodians of the land over there this morning, and I'm really delighted to be joined by so many colleagues in Australia who are also championing the cause of personalised care and social prescribing. If we were all in the room physically with each other today, you remember those days when we had conferences when we actually drank coffee with each other and chatted before the event. If we were there, I would start by asking everybody a question. And that question would be whether or not you love to be excluded from the decisions and conversations that affect the most sensitive, intimate, and worrying aspects of your lives. I'd ask you to raise your hands. And when I've asked this question before, not many people put their hand up. A couple try it on sometimes, but majority of people agree that they do want to be included in those decisions. But it's interesting when you look at healthcare and survey patients and their experiences across the world. Certainly in England, 40% of people say that they're not involved in decisions about their health and care in the way in which they would want to be. And we also find that when we actually do include people, 40% of people don't understand the information that they're provided with by the healthcare system. And 40% of people also living with long-term conditions and complex needs say that they lack the skills, knowledge and confidence to properly achieve their goals. So we have a health system that actually doesn't directly include people as well as it needs to. And there's a great piece of technology that we have available to us. I don't know whether everybody has got this available in their toolkit, but that amazing piece of technology is called Conversation. And it's an interesting thing, really. Do we actually use conversation enough in healthcare settings? Do we actually ask patients what matters to them? Do we ask them, how they're getting on with the various treatment options? Do we just focus on what's wrong? So personalised care, for me, is about trying to change this paradigm. It's about creating the opportunity for people to have choice and control over the way their care is planned and delivered. And that's based on what matters to them. And importantly, it builds on the assets that they bring to their own care. Because clinicians will always be experts in conditions or diseases. We need experts like Nancy and oncologists and surgeons with huge amounts of expertise. But people are also experts in themselves. I mean, we've all lived with ourselves since before we were born. It takes a bit of a while to think about that, actually, since before we were born. But, we've lived with ourselves for a long time. And actually, wouldn't it be great if we can combine that expertise that individuals bring to their own care and the assets that they have in their lives, their communities, their families, with the expertise of clinicians. And that starts with a different conversation. It starts with something that we call shared decision making, where you can tap in to those assets by just asking people what matters to them. Now, this isn't necessarily right in all circumstances. Hopefully no one will be today, with the streets being as quiet as they are today, with various measures that we're living through, obviously over both here and I know obviously you're having a difficult time in Melbourne at the moment, but hopefully no one will be knocked over. But if you are knocked over and you're lying semi-conscious in the road, you don't necessarily want the paramedic leaning over you saying, what matters to you the most? What does a good day look like? This isn't necessarily a conversation for all types of clinical practice. Sometimes we need clinicians with the expertise to support us just to use that expertise. But actually, in other settings, it is, I think, the most powerful question that we can ask. And it starts to tap in to a different way of supporting people. So that's just a bit of context setting for personalised care and what I think personalised care means. I just want to talk to you a little bit about the journey that we've been on over here. And then I'll share with you where we currently are at in that journey. And then just try and give you a few ideas based on our reflections of what's worked and what hasn't worked so well. So in terms of personalised care, when I look back at probably 5 years ago, because this journey's been a 5-year one for me, and that's led to what you can see in front of you, our comprehensive model for personalised care. And it's always good to start with a triangle. I think triangles always work in life. This is a model that's quite simple, quite straightforward. But what did we do to create this? Well, we started by looking out at what was going on across the country. So I was set a challenge that was somewhat of an oxymoron because I was asked to industrialise personalised care. And in order to do that, I thought, well, what is going on across the country? And what we found by looking out across England was that there was a huge amount of progress. There was lots of individual streams of work, lots of very forward-thinking clinicians, commissioners, people working in the voluntary sector, people in social care and in health settings who were delivering different aspects of personalised care. And we found that there was a huge amount of energy in various movements as well. For example, we had a long-standing tradition of disability rights over here, where disabled people had called for choice and control and nothing about us without us. From the 1970s and 1980s, a sort of civil rights movement for disabled people, where they were looking for increased ability to self-determine. And that had been around for a long while, and that had led to the creation of personal budgets, direct payments in social care, and personal health budgets in health. But that wasn't connected to other movements that were going on. So at the other end of the spectrum, you had clinicians who were starting to realise the limitations of the medical model. We've gone through a couple of revolutions in medicine, from the first revolution that was probably about sanitation and running water. The second revolution, the modern medicine movement with surgical procedures and antibiotics and advancements in technology. But actually, we were starting to see that certain things were creating limitations. They'd started to recognise that there were big problems with opioid overprescribing, big problems with antidepressants, and wanting to look at the opportunity to deal with health in a different way. Apologies, I don't know whether you lost the connection then. Nancy, am I still connected? Still good, thank you. Apologies, everybody. So clinicians looking for a different way of providing their care and support. But actually, at the heart of both of these movements, whether that was the disabled people's movement or it was the clinical profession realising that there were limitations in what they were looking at, was this concept of choice and control, was this way of tapping into individuals and what mattered to them. So we looked out at what was going on, because despite the fact that there were these huge opportunities going on across the system, they were somewhat fragmented, and they were quite separate from each other, and there wasn't a model to bring them together. So that was the creation of the comprehensive model. And what we did is we worked extensively with communities. This was a collaborative development process. We worked over a period of 2 years where we went out into individual areas. We brought clinicians, we brought people with lived experience, we brought social workers, commissioners, people together from all areas of the system. And we said, look, how can we pull all of this together in a model that works for both patients and clinicians and system leaders? And that led to this operating model. So this was extensively co-produced, and I think that's one of the most important parts here, that this isn't a top-down model that's been created by myself and the team in the NHS and imposed on the system. This is truly a bottom-up model that's been co-created by thousands of people. And that's given us great strength, I think, in the way in which we've now begun to implement it. So there's 6 components. It starts with shared decision making, that conversation, that changed approach. And we find that with shared decision making, opening up that conversation with people, we have different results. So shared decision making conversations are done well. You can reduce costly and risky treatments by up to 20%. So just by explaining to somebody, for example, what the likely impact of taking the antibiotics may be, and whether or not they would recover without the antibiotics, whether there would be counter issues related to the taking of the antibiotics, you tend to find a different result. So shared decision making reduces costly, risky treatments. Then we recognise that people need plans. Personalised care and support plans are about bringing all of the care together holistically, so that you're looking very clearly at people's whole life. Very often healthcare systems try and put things in silos. They try and compartmentalise what's going on with somebody. Nobody has cancer on a Tuesday and mental health issues on a Wednesday. That's not how people's lives work. But actually, when we do support planning, we tend to focus on their cancer and focus on their mental health separately. So personalised care and support planning is aimed to cut through that. Just to mention the box on the bottom left, this isn't about throwing out medicine. This isn't a challenge to medical pathways. It isn't a challenge to drugs. We still love the drugs. We still need the medical procedures. This is about working alongside that biomedical model. It's about embracing the biopsychosocial model. It's not saying, look, let's stop using pharmaceuticals and just move on to alternative methods. This is about looking at a really comprehensive system. So then we have the 3 boxes which are really important underneath: social prescribing, community-based support, supported self-management, and personal health budgets. I'll just start with personal health budgets. We introduced over here about 10 years ago now the opportunity of personal health budgets in health. That effectively is an amount of money. It's not new money. It's about using the resources that are supporting somebody directly in a way that best suits them. So it's very similar to your NDIS system over in Australia, but I think has lots of features of your NDIS system which go beyond what we've done with personal health budgets. But in relation to our personal health budget system, it's about giving people true choice and control. So rather than, as Robin, one of our members of a strategic co-production group, says, she was having 38 carers a year from her care agency when she had services directly provided to her. So on any day, she'd have a total stranger turn up to provide some of the most sensitive and intimate care that she needed. But now she employs a team of 5 PAs, personal assistants, that she knows, that she's relates to, and she's able to have much greater control. But actually, it's also 19% cheaper for the system to deliver that type of care. So personal health budgets are really taking root here in areas such as mental health, in physical, personal, domestic care support, wheelchair service to enable people to purchase the equipment that they need. And that's proving to be an effective model, both in terms of improving the outcomes for individuals, but also outcomes for the system as well in relation to cost. In relation to supported self-management, we recognise that building skills, knowledge and confidence, back to that point that I made at the beginning, around 40% of people lacking skills, knowledge and confidence. We've started looking at ways through health coaching, through peer support, through developing skills. So, if somebody's newly diagnosed with type 2 diabetes, why are we not automatically sending them to college to become an expert in type 2 diabetes and an expert in managing that condition? So looking to build the knowledge. And we find, if you look at patient activation, I know there's been some experimentation in Australia with patient activation measurement scores. If you look at patient activation measurement and you take people from activation level 1, the lowest, to activation level 4, the highest, you can reduce GP visits by 19% and admissions to hospital by 38%. So, there's significant opportunities to be had by improving the opportunity people have to self-manage, both in terms of their outcomes in the system. And then turning to social prescribing, community-based support. This is truly a new revolution, I think, over here. We're starting to see huge momentum for social prescribing. It's not that it's not been around for a long time. Really forward-thinking GPs over here, such as a man called Sam Everington in Bromley by Bow, and Michael Dixon in Columpton in Devon, probably been practicing versions of social prescribing for about 30 years in their practices. But actually, it's only recently that we've started to really see the significant opportunities that that brings. And as Nancy said in her introduction around the fact that you sometimes see a patient that actually doesn't need a medical prescription. What we find over here is at least 1 in 5 people are going to see their GP with purely a non-medical need. It's a relationship issue, it's housing, it's debt, they're lonely, they're socially isolated, but there's no medical condition linked to that need. But additionally to that, probably about another 40% of people have a medical condition that actually would also benefit from a social response. We've spent a lot of time injecting people with cortisol into hips for arthritis and other things, but actually, would swimming be a more effective support for those individuals? So it gives us the opportunity to look at care and support in a different way. It gives us the opportunity to tailor support to people that is closer to their home and in their community setting. Thank you for the next slide. Apologies, I seem to drop out again. Hopefully you can all hear me again. So this shows a little bit of a timeline in terms of how we have implemented social prescribing. I mentioned the program of collaborative development that was called an integrated personalised commissioning program, and we've built this up gradually over the years. So we started with just 6 demonstrator sites, we moved to 9, and then we moved to 18. We then moved to 1/3 of the country engaged in delivery of the comprehensive model. Before now we've rolled it out across the whole country. And in terms of momentum, what we decided back in January 2019, last year, was that we would produce a document which was called Universal Personalised Care, that led to the creation of a 21-point action plan to scale personalised care across the whole of the NHS. So by working very, very carefully with communities, building this up slowly, we then got to the point where there was so much momentum, so many people were engaged in the delivery of this model, that we felt that it was the right time to make a big shift into the mainstream. And in 2019, we also published the NHS Long-Term Plan, which was a 10-year plan for the future of the NHS. And personalised care was implemented in that as one of the 5 key shifts for the NHS. So we set out that we wanted a universal model of personalised care, alongside reform of accident and emergency departments, a reform of general practice, reform of outpatients, and a significant increase in the digital technology that's supporting the NHS. So it's right in the centre of the reforms over here for healthcare. In terms of the social prescribing then, in relation to how we've moved forward with that, we've recently launched a new 5-year contract for general practice. And that requires general practice over here now to implement a social prescribing scheme in their areas. And because of the significant interest in this, we've embedded it in the contract. So it's now woven into the healthcare system. It's not just something that sits alongside as something that's nice to have. We're saying that social prescribing and personalised care is a fundamental part of the way in which we deliver healthcare over here. And we've invested £500 million in the development of a link worker network. So over the next few years, we're going to be putting in place 4,500 link workers alongside around 2,000 health coaches and 2,000 personalised care and support navigators that will all sit in primary care. So we'll have 7,500 to 8,000 personalised care staff sitting in primary care that will be delivering the comprehensive model that I've just shared with you, having those conversations, working out a plan, looking at connecting people to community groups and activities that matter to them, and delivering hopefully a new method of care and support. And we've been accelerating the number of staff in those roles. This time last year we had 300 people. We now have 1,275 link workers in primary care. We'll have another 500 coming on board by the end of this calendar year, hopefully getting to around 2,000 by March of next year. So it's a rapidly growing workforce. You see on the right hand side here our standard model for social prescribing with those component parts. And one of the things that we made sure we did in universal personalised care was stipulated very carefully the key aspects of each of the components of the personalised care model. So this is the detailed plan for social prescribing. With social prescribing, we break it down into 4 zones. So fantastic opportunity that comes from social prescribing, but the 4 zones I think are really important for us. And again, Nancy mentioned some of those in her introduction, but the first is art and culture, connecting people to things like community choirs and dance, opportunities for dance for Parkinson's, supporting falls prevention through professional dancers going into care homes, because dancers are very good at falling, as well as creating beautiful movements on their feet. They're trained in how to fall properly, and opportunities of just connecting people with the arts in a different way. Now, you know, in Melbourne, whether or not that's going and viewing art on Hosier Lane, or that's going to the National Gallery and looking at Monet, you know, it's about tapping into you know, what really matters to people. The second zone is physical activity and sport, encouraging people to take part in activities and increase the opportunity for movement. The third is nature and the green environment, and you know, we can't compete over here with the abundance of parks and open spaces that you have in Melbourne. And I was doing a bit of research actually on some of your parks. I was looking at Carlton Gardens, and there's also Monument Park, so you know, from very traditional to very, very modern. You also have a park, I think, which is called CBD Park, which I think you may have run out of names to call them, or interest in names, but I saw that on the map as well. Yeah, great opportunity and growing evidence base around the natural environment. And then the final category, the fourth category, is about information and guidance. You know, giving people the knowledge capital that they need to live their lives well. So across those 4 zones of social prescribing, we're really trying to increase the momentum of connecting people to those things. And then this next slide shows where we've gone next. Secretary of State over here for Health and Care asked me to look at setting up an independent body last year to champion social prescribing outside of the NHS, because we're finding that it's such a great opportunity across government departments and across community groups. So we formed NASP, the National Academy for Social Prescribing, with this simple mission to raise the profile of social prescribing, both at home and internationally. And it's really fantastic that there's such a global alliance growing for social prescribing. You know, the work that's been happening, led by Leanne and others in Australia with the Consumers Health Forum, and then fantastic opportunity that is happening in Melbourne now, with a number of organisations looking into it. But we were also seeing growth in Canada and Singapore, in Russia, in Lithuania, across many countries now. There's a real interest in social prescribing as a mainstream offer with healthcare systems. We're looking to find resources for the voluntary sector, so the lifeblood of social prescribing activity, looking to build relationships at a national and local level, improving the evidence base. Evidence is improving all the time for this intervention. It's sometimes a challenge that's pushed, but the reality is there's an abundance of evidence of the benefit of social connection and the benefit of physical activity. And finally, we want to share and spread best practice and also learn from other areas and other countries around how social prescribing can support people. So we have a great opportunity, I think, over here at the moment with the momentum that we've got for social prescribing. And I think over the next few years, we'll really start to see it come into the full mainstream when we get up to the numbers that we need. We've also launched, as of yesterday, a Personalised Care Institute, which has been launched in partnership by the NHS and the Royal College of General Practitioners and a number of other Royal Colleges representing the other clinical professions. We launched that yesterday, and that will be a national training institute for personalised care, bringing the opportunity of personalised care to clinicians, because we recognise that this is a new area that people need training on. So we have a significant movement now with the National Academy and the Personalised Care Institute and NHS Personalised Care that's driving this forward. So just in conclusion, a few things just to share then. Our experience of putting this into place is that it is complex. It is not an easy shift because there's a huge cultural shift that comes with this type of approach, going into a medical system that's existed in a similar way for many years. But I've got sort of 6 takeaways really. The first is what I mentioned early on in my talk, is about working on what's already there. Look at what's already in place. There will be an abundance of good practice in personalised care going on across the country, and it's not necessarily about inventing anything new. It's about connecting the dots with what is already there. Make sure you co-produce the solution, get people bought in at all levels, so that this is truly a combined approach of that bottom-up social movement with the infrastructure that comes from national organisations. Ensure there's a clear model. I think the system needs a model that everyone can get behind, so a model that's got very clear specified parts. Make sure there's buy-in from all parts of the system as well. Create a bold move. There's no sort of way of ramping this up. I think you've either got to implement it or not. So there's an element of actually just getting to that point where it's, well, we're going to embrace this now, and then have to move forward with it. And then the final thing is sticking to it. A lot of healthcare systems that I've recognised love reinvention, and we love coming up with a new way of doing things every 3 or 4 days. But actually sticking with it, if it works, and making sure it's fully implemented, I think is a good thing to focus on. Thank you very much. Apologies that I had a couple of technical glitches, but hopefully that worked across the talk. I'll hand back to you now, Nancy. Thank you.
In fact, sure, you'll hand right back to me. It's Rob Moody here. So thank you very much, James. Wonderful, wonderful discussion, wonderful presentation, and particularly that last slide of what are the key elements that we might learn from your experience. I'm actually still coming to terms with the notion of living with myself since before I was born, but I'm sure I'll be able to finally come to terms with that. We've got lots of really interesting comments and questions online, and just there's many, but just maybe come back to the link workers. Just if you could talk a little bit about, what are their qualifications, what are their qualities, how that's being developed, that whole area.
So the really great thing about the link worker role is that it is incredibly diverse. So there's probably 3 main groups of people that are becoming link workers over here. We're not specifying any specific qualifications. They don't have to have a clinical background. We really need people that are connected, that are great at having that conversation, that have got experience in various aspects of community work. But we have, as I say, quite a diverse group. So probably the majority of link workers are people that have got huge experience in community organisations. Those people that have worked in the voluntary sector for perhaps 20, 30 years, that have got significant knowledge of what is happening in their local area, so that they're able to make those connections with people. We are also seeing a lot of younger link workers who are people that have perhaps left college, who are partway through or have completed training as an occupational therapist, or have gone into psychology, or lots of other areas, but are not yet starting their career path in their chosen subject, but want experience in the healthcare setting. And we're seeing a lot of people retiring from clinical practice as well, who are taking the opportunity of still working, but in a different setting, in a different way. So we've got retired paramedics and OTs and nurses that are also signing up to become link workers. So within a local team, and we're expecting about 3 to 4 link workers per primary care network. Over here, primary care networks probably support around 30 to 50,000 people. Within that team, you'll tend to find a bit of a mix. So there'll be people with that community experience. There may be one person that's got a clinical background. It enables a lot of interesting skills at that local level. But it's a really, really diverse role.
Lovely. Thanks very much. That was for Martha. This is from Hilary Bush. I like how this is embedded in primary care. However, how does this work in practice where perhaps systemic issues such as poor communication between the primary, tertiary and community sectors might impede the efficiency of the model?
I think that's a real challenge that we still need to overcome, actually. We're seeing growing interest with the connections, mainly in terms of mental health trusts in secondary care, and the opportunity of connecting people back from secondary care settings into the link worker service that's operated in primary care. One of the things that we've been really careful not to do is create link worker models in all settings, because I think there's benefit of having a really robust model sitting in primary care that then can act as a hub for other services to refer people into. So the referrals do come from other settings at the moment. But in terms of that journey that people make around the system, and that comes back to the role that we are putting in, but we're not yet mature enough, which is this care navigator role, this personalised care navigator role, which would be somebody to actually support the individual with the various connections that they have in the system, whether that's the primary or secondary care.
Right, lovely. Can I just ask, this is from James Sanderson, who runs or governs or manages the National Academy for Social Prescribing?
I'm currently Chief Executive of the National Academy, so I have a combined role at the moment with the NHS and with the Academy. We've got a small board of trustees, and we became an independent charity a couple of weeks ago. So we set the Academy up as a community interest company, but we're now a fully fledged independent charity, and we're putting in place a staffing team in order to take that work forward. So it's sitting outside of government. We've had some backing from government and from the NHS, but we're looking to now scale the organisation to provide a national voice for social prescribing alongside the work that the NHS is doing. So it's, in one sense, we've got the National Health Service building the infrastructure for social prescribing with the link workers in place and the contracts in place. And the National Academy is looking at the context for social prescribing, looking at the way in which national, local organisations work together and how the voluntary sector can support social prescribing to thrive.
Lovely, thanks. This is sort of quick fire answers. We've only got 35 to go, but from Monica Ferry. How important is localisation in care planning, and how does it happen in the UK? And you might also want to consider the fact that linking to local governments, Peter Brooks mentioned this, you know, that can be fairly difficult. How have we done that in the UK?
I think, again, I mean, you're picking up on a really knotty challenge that I think a lot of countries will be battling with, that sort of degree of balance between national implementation of schemes and local determination. And I think there is a fine line of how you balance those things out. I mentioned that we'd co-produced the solution, so we'd worked very, very locally, but then it led to a model that was a national model, and we have been very clear to specify the individual components of that. So there has been some challenge on whether or not that's too specified at a national level or requires local adaptation. And you know, we get, as I'm sure you do over there, we get the challenge all the time of the people of Portsmouth are different to the people of Stockton-on-Tees, and yes, you know, there are different aspects that individual local communities need to take account of. But what we've found is we've created a model that is flexible enough to be adapted whilst not losing those core components. So we've said, for example, you know, with personal health budgets, there are 5 key features of personal health budget, and they have to be in place for it to conform with the model. However, building new opportunities around that, building new ways of delivering it is of course absolutely fine. It's about ensuring that you know, the active ingredients in the recipe is the same, but how you serve that dish at a local level can be adapted to local taste. And I often use the analogy of making pancakes. You know, if you give people the ingredients without the methodology, they may make a Yorkshire pudding rather than a pancake. But actually, you know, if you need pancakes, you've got to have the recipe as well. But the local area, serving those pancakes with blueberries or with ice cream or with spinach and ricotta cheese, is down to that local area to fit it for the needs of their population. So I think
I'll have to interrupt you here. It's got to be maple syrup.
All right, of course, yeah, of course, maple syrup.
Thanks, James. Thank you very much indeed for having go to those questions. We won't be able to answer all of them. Given that it's nearly dinner time, he really sort of just stimulated certainly my appetite. And we will move on to the panel. We'll come back to you, James, for sure. I'm sure in the questions again. So I'd now like to introduce the panel, and we've got first 2 terrific speakers, Charlotte Hespy and Sandra Di Meo. And Charlotte is going to really focus on what's the need here from an Australian point of view. Sandra will present it more from a Victorian point of view. And I'll just quickly introduce Charlotte. She's working part-time general practice in inner city Glebe as a principal of a 19-group GP group practice. She's also head of general practice and primary care research for the University of Notre Dame. As a GP, both researcher and practitioner, she's ultimately, you know, integrally involved in this whole area. So we're delighted to have you, Charlotte. So over to you.
Thank you, Rob. And yes, and can I reiterate that as a GP, I've been passionate about social prescribing ever since I started, but I didn't know that's what it was called or that it even had a name to it. Before I start, though, I would like to acknowledge the traditional owners of the land that I'm meeting on, which is the Gadigal people of the Eora Nation, and pay respects to elders, both past, present and upcoming. So the context for me as a GP is that right from the very start, I was struck that an inordinate amount of the care that I needed to give was actually around the social support and the need to find other things around assisting care, and that the sort of the medicalised model that I'd been taught as a doctor was absolutely essential for the foundation of how I delivered care. But actually that whole thing that James has been talking about, the personalised care and the need to bring in other things, was actually a key part of the role that we played in general practice. And so these stats that are up on the screen at the moment are sort of part of that sort of understanding. I did a sort of a little survey of my patients just fairly recently, where I sort of looked for a couple of weeks at how often I needed to actually bring in the sort of social prescribing part of my role. And it was actually 60% of the patients that I was seeing. And I was struck by that that's a large number when we actually don't talk about that in the medical model of care that we teach through medical school. And, you know, there is very little acknowledgement of the role, the important role that that plays in being able to get people better. And those stats, as we see there, are really sort of very, very striking, that 90% of Australians will see a GP every year, and the most common health issue that they bring to general practice is actually around our psychological health. And so we need to be actually upskilled in what that looks like. And certainly in general practice, there is no formal sort of model of being able to enable us to do it better. Again, if I sort of thought about taking it to my patients to find out if the stats, you know, 1 in 4 Australians are feeling lonely. Well, is that, you know, is that really true? Is that relevant to my practice? So we sent out a survey monkey to all of the patients in my practice, and I was struck by how many people actually responded. We've got 6,000, just under 7,000 active patients, which means that patients are actually coming to the practice for the last 2 years. We don't have registration, James, just for your interest. So you can go anywhere and see anybody at any time. But in fact, Australians generally do find a GP practice and GP that they like. And of my patients, in fact, there was 30% who actually said that they were lonely. So not the 1 in 4, but, you know, to actually acknowledge in a survey to your GP that you were lonely, I thought was very striking. And they did actually say that, you know, that they knew that meant that their health wasn't as good. And they also, I was struck, we had, again, 15% of people had told us that there was, in that last 2 weeks, there had been a time when they hadn't had enough food at the table. So these are not issues that are not for, you know, everybody. And where I work is across the mix of everybody from very wealthy through to the very poor. So it's quite a good demographic to be sampling. So the RACGP is, I think, is definitely at the table. They know that we need to do something about it. It needs to be more than sort of just talked about. We need a system. And we need to be able to have sort of a clear model of knowing what to do. For me as a GP, the hardest thing is knowing what are the places that I can send somebody to. What are the resources that I can access? Because a lot of the time they move around. So what I know today, and maybe the next time I need that particular resource is actually, say, 9 months later, it may no longer be in existence. And that's a classic thing in the health system that I work in, because things get funded and they're funded for a couple of years and they may work, but they still lose funding. So all of a sudden this really great program is gone. And so being able to keep up to date, have somebody who can actually assist in being able to go through that has been particularly striking from mine. The final thing I'll say before I go is that please do make use of GPs in this. GPs are trusted. They actually have very good relationships with their patients. And we see the patients who are most socioeconomically disadvantaged actually do see their GPs more frequently than if they aren't. So we are really missing an opportunity if we don't utilise that key role that GPs play. Despite the lack of formalisation of registration, we actually have an inordinately powerful and underutilised role in the healthcare system in being able to link in not just medical interventions, but that whole social prescribing. And I'm so excited to think that we can finally get some more formalised models up. Thanks.
Great, thanks very much, Charlotte. And just a comment from Marie Maxfield here saying, do you realise how many services and systems tell people to actually take it up with your GP as ubiquitous advice?
Yeah, and I think that's the thing they do say, take it up with the GP. I think the hardest thing is actually for the GP, because as a generalist, we are expected to know something about everything. And so this then goes back to systems of care. We need to have a better collaboration, better communication across all systems. So we're not reinventing wheels. We're not trying to find out information that somebody else found out about a week ago, yet no one's bothered communicating it to us, etc. So yes, I think the public is well engaged with GPs. Actually, what I need us to call upon is the rest of us to collaborate together and to have much better systems of communication, because that really is, it's key.
And I think, Sally Brown makes the comment too, slightly more challenging, is how can we get Aussie GPs interested in taking the time to socially prescribe? And you're suggesting we can.
I'm suggesting that we are already doing it a lot of the time. There may well be GPs who don't, but often some of the GPs who probably don't do a lot of the things that, we're not talking about. So we might leave them in one part of the curve, go with the curve in terms of about delivery of quality care. And we're doing it. A lot of people don't have that name. The social prescribing name still hasn't really sort of seeped into the mentality, certainly not of GPs. But when you explain what it is that you're talking about, they all, I do it. I do it. I just don't call it that. And I might spend hours of unpaid time chasing up how to do it. So they'll be very keen to actually have it part of their formalised care, rather than it just being the things you do extra that take up an inordinate amount of extra time.
Thanks, Charlotte. Thank you very much indeed. And now I'll ask Sandro De Meo to present. Sandro's giving us more the state view. Sandro is the current CEO of Vic Health. Follows a long line of great CEOs. No, and he's a medical doctor, renowned public health expert and advocate. He's previously worked for WHO and the EAT Foundation in Oslo. He's founded NCD Global Social Movement. He's author of Doctor's Diet Cookbook, and he also co-hosts the ABC television and Netflix show Ask the Doctor. So now's your chance to ask the doctor. So over to you, Sandro.
Thanks very much, Rob. And it's a pleasure to be here. I'd also like to just start by acknowledging the traditional custodians of the land I'm on, the Wurundjeri people of the Kulin Nation, and their elders past, present and emerging. We can't really talk about the state of health in Victoria without first reflecting on life pre-COVID and then the impact that the coronavirus has clearly had on that burden. But I suppose the snapshot, which we've already heard and we know largely coming in, is that the need is enormous and the opportunity is equally enormous. Much of the burden of disease facing Victoria outside, well, including across an infectious disease pandemic, is preventable. We know that the leading causes of death across Australia, things like heart disease, diabetes, chronic lung conditions, the so-called non-communicable diseases and their modifiable risk factors. The opportunity to work further up the causality chain and influence those behavioural risk factors, in addition to, as James said, continuing to provide world-class and universal healthcare, that is, pharmacotherapies and other interventions. But we really need to continue to shift. We need to continue to go down the journey of shifting our gaze further up that causality chain and really actually turning off the tap of preventable chronic disease, rather than continuing to treat the outcome, which is unsustainable, but also leaves a huge amount of avoidable burden in the population. And then along comes coronavirus, and this has fundamentally changed every aspect of our life, and with that, the health of populations across Victoria. And we're actually just published today a survey that we undertook of 2,000 Victorians back in the first lockdown. We'll repeat the survey in a few weeks' time, and those results will be out in about a month's time. But we saw many of the challenges that Victorians were already facing have worsened, and that those most vulnerable have been hardest hit once again. So, you know, for many decades, we've been living with a chronic disease pandemic. Margaret Chan famously described the global burden of chronic disease as a pandemic in slow motion, which it is. And now with the superimposed infectious disease pandemic, what it's doing is it's accelerating many of those risks, but it's also further concentrating that risk and that burden on those least able and with least resources and access and health resources to be able to withstand and navigate that. So, you know, we are seeing what we saw in the latest results. 1 in 4 Victorians feel socially isolated, more than a doubling since February just this year. We saw very high rates of social disconnection or social isolation, which we know is an important precursor for the mental health of populations, closely linked with things like anxiety, depression, and other burdens of disease. We saw particularly high rates in First Nations Victorians, 1 in 2, but also young Victorians, 18 to 24, particularly young women, Victorians who speak a language other than English at home, and those on JobKeeper or JobSeeker proxies for either unclear work or low incomes. In terms of healthy eating and access to affordable, nutritious diets, again, we saw a very large spike in food prices across the first 3 months of 2020 with drought, the bushfires, and then panic buying in the early stages of coronavirus. And we now see 1 in 6 Victorian families and households struggling to put any food on the table. 1 in 4 single parent households having to go or not being able to restock food in their household due to economic pressures. But we also saw some interesting positives. We saw people eating less takeout and cooking more at home, largely due though to economic pressures. And finally, you know, physical activity, again, 3 really core areas where social prescribing can be so helpful. We saw a decrease in the physical activity levels across Victorians. So 2 in 5, almost half, 2 in 5 Victorians were less physically active across the lockdowns. And again, a strong social gradient. Those that were able to, that had a backyard, that had access to green space, that lived in neighbourhoods where there were good, high quality infrastructure, they actually found themselves exercising more. Whereas those living in precarious housing or low quality housing or with less access to that green infrastructure, they found themselves exercising less. And of course, all of these actually, all 3 of these and more, particularly psychological stress, which we saw an increase in as well, are all, again, concentrated in those low-income groups. So I suppose, you know, what we're really thinking about is how we're talking a lot as a global community of how we build back better. And I think we really need to acknowledge that we need to build back healthier as well, that we can't just aim to re-achieve our baseline level of health of the pre-COVID era, where 2 in 3 Australians are overweight or obese, 1 in 4 of our children, and the leading risk factors, the leading drivers of death are largely preventable, at least significantly delayable. That can't be the baseline that we go back to, or the normal that we return to. We need to be thinking about how do we build back better, and with that, it needs to also be a rethink of our health system, a greater focus and push to prevention, and really once and for all working with the medical community to see, I think, social prescribing's great opportunity to really bridge the gap between prevention and the healthcare system, and see work with GPs who very often want to be enabling and providing earlier opportunities to stay healthy for their patients. And I think this really provides a great way forward. And finally, I'll just say that we today, I think one of the messages was, work on what is there and focus to a degree on local solutions. We today launched $2.5 million worth of a new grant round focused on exactly that. So supporting local organisations, local communities, local solutions to the different health challenges that Victorians are facing and will be facing over the coming 12 months. And you know, we would be really interested to look at local pilots or local models that do bridge the healthcare to prevention gap, and how our funding might be able to support some of those early stage pilots through our Reimagining Health grants. Thanks, Rob.
Thanks, Sandro. And if you can actually give us the link, we'll put the link up for everybody to your announcements today. Thank you very much indeed. There's just two questions here that I'll leave for James and for the panel as a whole. I'll come back to you a bit later, but they're the two most popular. One is, while appreciating that this model has developed out of co-production, the term prescribing still infers a power differential, that is, the health worker remains in control. So I'll leave that with you. The other one is from Rodney McIntosh, really interested in the evidence and any examples of how social prescribing has been used to address social isolation and promote community connectedness during the COVID-19 epidemic. Melanie Tai has already given an example, but thoughts on its role in the recovery. So I'll come back to those two questions a bit later. But now I'd like to really move on to some great case studies. We've got Tracy Johnson and Megan Tucciarelli to provide those. Tracy is going to start. She's the CEO of Inala Primary Healthcare, a charitable multidisciplinary teaching and research active practice in Queensland's most disadvantaged suburban locations. So Tracy, over to you.
Thanks, Rob, and thanks everyone for coming along tonight. Hopefully sometime soon you're going to get an image that's all too familiar to us. So normally when you see general practices and their websites, they have lovely pictures of beautiful waiting rooms and well laid out clinical spaces and smiling GPs. So the image that you actually can see there periodically is actually an image taken from the back of our GP practice. So 4 of our consult rooms actually overlook the house that has that beautiful artistic garden setting right out the front of its house. So not surprisingly, we work in one of Queensland's most disadvantaged catchments, and the house that you're actually looking at is a social housing house, because that's the sort of suburb that we serve. So I guess my response from the field when we're dealing with folks with such tragedy in their lives and often such difficulty is, what can we do? And I think too often we apply Band-Aid solutions. So across the top of my slide is my version of a Band-Aid. So the sorts of Band-Aids that we've applied are in fact social prescribing models. We've been lucky enough to actually have one of the hospital systems in our community, Mater Health Services. They're a Catholic funded hospital system. Through their benevolent fund, provide to us a nurse to do care coordination and social prescribing with our multicultural communities, because this is Queensland's largest refugee and migrant settlement area. We also have nurses and doctors who use the Medicare schedule to do chronic disease care planning, because in catchments like ours, everyone has some form of chronic disease. So when our nurses spend an hour with each patient at the beginning of the year doing a new care plan with them, they spend a lot of time working with those patients on shared decision-making, goal setting, and indeed diversionary efforts that might mean that their depression, their activity levels, their eating, etc., all improve. So that's also part of our social prescribing response, and it would be fairly familiar to most GP practices. The final model that we have is funded by our Primary Health Network. Again, it's a trial, and they've actually given us access to a social worker who comes and works out of our practice, dealing with some of our patients who really struggle with so many elements of their lives. And a lot of their work has actually been about helping those patients navigate into disability funding, into aged care funding, into a whole range of other services and programs that as a GP, if we tried to do that, and we have in years gone past, it would take us hours and hours. So across those 3 models, we've done some studies, and on the right-hand side of the screen, it shows you the sorts of things that we've found. And basically, just as everyone's saying, starting with James at the beginning, if you do social prescribing well, your patients attend less. which in a community like ours, where an awful lot of our patients can be heart sink patients, having them attending less is good for them. It's safer for them, because if you put a patient in front of a doctor, they're much more likely to give them drugs, or they're likely to send them off for pathology, or worse still, get another CT scan, maybe their 5th one this year. Because the patients are presenting with pain that's unexplained. So we want to reduce their attendance, and when they are booked in for something that's reasonable, actually see them attend. And a lot of these patients have difficulty. They have high no-show rates. So social prescribing helps with that. We've certainly seen health literacy improve through these models. It's been a clear outcome that's been delivered. We've seen access to other services improve, which means that if they don't attend their hospital appointments, they don't get bounced to the very bottom of the list. But the most important thing, I guess, for me as the CEO of a team of 48 people here, is I've seen people's joy in attending work and their burnout rates improve. When you're dealing with patients of complexity, supporting your team to enjoy what they do and feel that what they do is done well is actually an outcome that we've seen improve through social prescribing. What have been our challenges? Well, if you listen to the reasons that a lot of our patients present, there's often a legal undertone to that. It's domestic violence, it's housing instability, it's debt, it's all sorts of other things. And they present with sleeplessness, with pain, with anxiety, with depression. So if we could also embed some element of a health justice partnership in the way we do social prescribing, I think that just as some of the Victorian models of health justice have shown, we'd get a much better result. I think from a GP's perspective, it's also hard if these services are virtual and outside of the practice, because life in a practice is literally funded by the minute. So if you have embedded models and you're constantly running into the people involved in social prescribing in your practice, you're much more likely to be able to incorporate it into your workflow and have productive handovers backwards and forwards between the healthcare team. I think as well, if we look at the costs that some of these people have to the healthcare system as a whole, and we say, well, how do we take some of those costs out of the healthcare system and put it into better support for these patients? What we in fact find is that we can deliver better care, but we need to do that in such a way that we don't pass on costs to other not-for-profit organisations in the social care sector that might not be particularly well funded. And I guess our final concern and frustration, and you've seen from my little band-aid at the top of my beautiful image, is that the longevity of a lot of these programs is often not great. So I would be the first to say that we need a national social prescribing approach in this country that supports what GPs, nurses, and so many other people delivering healthcare have been doing for so long in a really formal and structured way. Because from my perspective, when I'm paying GPs the rate that they absolutely deserve per hour to do what they do, it makes no sense to me that part of that time is tied up filling out paperwork or chasing around where different workshops and programs are being delivered, if that can be done by a link worker or a nurse or someone else. So that would be my experience from the field about why we need a better approach, we need an embedded approach, and we need to really recognise this as a formal part of our health and social care system.
Lovely. Tracy, thank you very much indeed. That's wonderful. We'll take another case study now from Megan Trucciarelli, who's the Senior Manager of Innovation and Community Care at IPC Health, which is in the west and southwest of Melbourne. So Megan, straight over to you. Thanks.
Thanks, Professor Moody. And I'd just like to pay my respects to the elders and the traditional owners of the Kulin Nations, of where I find myself today. I'm very pleased to be here and talking about IPC Health's social prescribing program in our Deer Park area, which is in Brimbank. It's Melbourne's west. We are a community health service that stretches across 4 LGAs in Melbourne's west, where our community is very culturally diverse and have a lot of socioeconomic disadvantage. Our purpose is to really improve the quality of life of those community members, and we do this by trying to maximise their access to holistic health care and wellbeing services, and social prescribing becomes fundamental to this kind of service model. Our project or pilot is funded by North West Melbourne PHN, and we started in 2018 in June with a lot of planning, literature reviews and research about what was social prescribing, mostly looking towards the UK and our international counterparts to what was going on there. By July 2019, we had a project officer and our first wellbeing coordinators, who in our terms are the link workers that we utilise. And by this stage, we opened up as a soft approach or referrals to our internal services. So our doctors, allied health professionals, counsellors, nurses, they were able to refer to us anyone they thought may benefit from the social prescribing program. So there was no eligibility criteria at that stage. It was really, let's offer this and see who gets the most benefit and just learn from the experience. So you can see from my slide, the wellbeing coordinator is key to this role. The referral comes in from a health service worker, and the consultation process is a really warm, conversational and friendly kind of interaction with the client. The first one might be over the phone, but the second one may be, meeting up in person or inviting that person to our centre, whatever is most convenient for that client's interaction. And basically what occurs there is a planning session around the person's current context, what they're experiencing in their life, what they wish to experience, their goals. This could be about wellbeing, healthcare, or anything really. In those scenarios, what we've discovered is a whole range of different issues get brought up. I think fundamentally the enablers of social prescribing and this practice is time. It's empathy and time that enables the wellbeing coordinator to really truly understand deeply the person's situation and then create the connections that they need to enable themselves to address those. When we get down to the activities, we are networking with a whole range of different people in the Brimbank area where our pilot's located. Often this is neighbourhood houses, this is community centres, it's not-for-profit organisations who are providing programs to community already. And what we do is facilitate a pathway of connection for the social prescribing client into some of those programs. If they have other needs around that identified that can be addressed by the health or welfare system, we're signposting those people into those services directly. So we've found lots of outcomes around getting people supports in an advocacy type nature with NDIS, My Aged Care, seeking out health referrals into other areas. But of course, the end pathway is always that connection back into community-based services. And the referral there is not a soft one. We actually work really closely with those providers of those services. But we have a reference group that comes together regularly to discuss and talk about that client's journey across the interactions and how they're going. We also have regular follow-up and check-in points, and we bring in the referring health professional back into that conversation to see how that's all going. So when we talk about this as an integrated model of care, it truly is. There's a number of different individuals and different organisations coming together over a broad period of time to support a single person in their journey. So far, we've had 147 referrals. Each one of those referrals is offered the service. Sometimes we have had a hit and miss where the social prescribing either isn't suitable for the person. For example, they might have acute mental health needs and a clinical referral was provided in that space. In other times, the person might decline the service or fall out of touch with us, which happens. But of all of those referrals, 72% have actually gone through with a social prescribing plan, which is excellent. And 60% have been able to engage in their activity. Obviously, in the circumstances for Victoria at the moment, with some closure of most of the physical activities, that's dropped off. But I recognise the question asked earlier about how we might have adapted our model during COVID-19 and the kind of situations we find now. There are a range of online programs, telephone-based social networks that we're connecting people in. We've done a trial in an art-based program with our social prescribing clients, where we've actually sent them ceramic and paint materials and taught them how to use Zoom and then bring them together to undertake that session within themselves. It's been fabulous. One of those individuals in particular suffers from social anxiety, and I know that in that space she was able to completely engage to the point where the group in themselves have become self-sustaining. So the facilitator actually took her holiday breaks over 4 weeks recently, and the group has continued throughout that time, which is fantastic. Some of the challenges and enablers I just want to talk to over the overall program. As I said, the wellbeing coordinators that we have found are nurses. They are nurses that navigate care coordination in previous roles, so they have a clinical component and a really good knowledge of the networks and services that are available to us. We have developed an asset list of different community-based programs that we talk to regularly. There's about 240 programs on that list at a local level, And we continually engage with those services to understand what's available for the clients and make a personalised offer to them about what's going on. It's in the service provision in itself, our flexibility in how we cater the care pathway is fundamental, not only for the client and giving them time to explore their issues and their needs, but also in the referring pathway, making it as simple as possible for our GPs and health service providers and those externally to simply get into contact with us and share details. We know this quick connection is really what makes that referral process the easiest part. So catching that person potentially even when they're in the clinic and walking them across to the social prescriber to have a first conversation and the first engagement has been one of the best achievement points to get activity based. And I agree with the previous comments about GPs and health services seeing the most isolated people. These are the individuals who will not be able to, by themselves, engage in the community centre or the neighbourhood house activities. They need a coaching and empathy type perspective. We use motivational interviewing to help them kind of become accustomed to their goals and where they'd like to go and build them up to be able to undertake that first step, and then warmly refer them into that avenue. And I think if we're talking about addressing vulnerability, it definitely needs to sit within a health service. What social prescribing is something broader that a lot of people are doing already, but the pathway of it from healthcare and primary care into community-based services is really the missing gap where we need to come together and strengthen.
Thanks, Megan.
Some of our challenges is about data collection. There's so many different systems to use. Keeping in touch with clients to get that in cases of vulnerability is really difficult. So we have some really great measures of success and profiles of client measurement, but using things like the UCLA loneliness scale and the Warwick Edinburgh mental health wellbeing scale, we haven't got a great deal of post-return surveys that could be part of our current context right now as a large part, but that's something we want to work on to actually absolutely provide evidence of the improvements that social prescribing have, and we're watching very closely our UK counterparts and Canadian counterparts as well that are providing some of this evidence, which is excellent. Community access was mentioned earlier, and that's something that I can't emphasise more. There's so much out there that can be drawn upon that we also need to provide funding to. I think COVID-19 has provided that as an example. We've had so many different volunteer organisations step up to the plate to provide resourcing in this space under crisis support. We're utilising them with our wellbeing coordinators as a referral pathway, and we hope to continue that post-COVID in a space where we start to look at psychosocial and social prescribing as a pathway to them as well. Thank you.
Thank you very much. Thanks, Megan. Look, just to let you know, there's a lot of questions that are actually directed for you, Megan, and for the other speakers. If they can, you can have a look at the Q&A. Please, you can answer them live. You can type in the answers now. Or sorry, you can type in the answers now. That would be wonderful. We're going to try and get to those questions later, if we can, after when this is finished, actually, to get back to you on. If we can, we'll try as much as we can to do that. It's pretty tough. There's so many questions that's so rich in terms of what you said. Also, some people in the audience is great are answering each other's questions. That's that's absolutely brilliant. So if you're seeing something, a question there, a comment, and you've got a response to it, then please use that. I think we'll have to go straight to you, Leanne, who's our last speaker and sort of going to help us wrap this up. By the way, but then I want to come back if we can for a couple of questions for James. Leanne, as I think many of you know, is the Chief Executive Officer of the Consumers Health Forum of Australia, a really fierce advocate of this whole approach of social prescribing. So we'll go straight to you, Leanne. Thank you.
Thanks, Rob. Good evening, everyone. Big task to sort of wrap this all up, but I suppose a couple of really quick observations. Social prescribing practice is not new. It has been happening across the board. I think we've heard that point made. I think what the point of difference I think we're talking about here is that we're calling for a systemic strategic rollout and implementation. I think Tracy used the term, a national social prescribing scheme. And why is that important? We think it's important because it's another way that we can meet the quadruple aims. So I just some quick takeouts from me, from James's presentation. Some of the really important things with this are it needs to be embedded in policy. It needs to have a clear model. It needs to be nested in a system of care. We need to invest in the enablers. It needs to be implemented locally and fit for purpose. And I love your expression, James, make a bold move. So how do we make that bold move in Australia? How do we keep up the momentum? So we do have stakeholder momentum. I think the challenge to all of us now is to work together as a guiding coalition, if you like, to harness, support and nurture that momentum. On the embedding in policy piece, we've got 10 new primary healthcare plans and a national preventative health strategy in development. That's an unprecedented opportunity to embed social prescribing into policy, and I think we absolutely need to work together to stridently advocate for that. And then there's added impetus coming from the Productivity Commission inquiry into mental health. I saw some comments about mental health and the absence of that in the discussion to date in the chat box, and the COVID pandemic disruptor. So all the needle's pointing in the right direction with this, I think, and the timing's right. But it needs an authorising environment, the policy piece, and local innovation. It's about meeting those two things in the middle. So I guess the call to action from this webinar today and the one CHF ran in collaboration with the RACGP last week was we need to keep up the advocacy. I think the call to action to all of us is to work together on establishing a guiding, coordinated national coalition to steward and campaign to set the agenda, that bold move that James talked about. And to stay connected both with ourselves and practitioners here in Australia, because we're going to continue to learn and grow our knowledge around this, and to stay connected with our international colleagues as well. So that was a very quick, in the interest of time, wrap up and some observations from me. Rob, back to you.
Lovely. Thank you very much indeed, Leanne. And we don't have much time left, but I did want to come back to you, James. And the top question of the day is really, as I mentioned before, while appreciating this model has developed out of co-production, the term prescribing still infers a power differential. The health worker remains in control.
Yeah, I think it's a really, really interesting question. And apologies, I've been trying to answer the questions online, but there's also a huge discussion going on Twitter as well, which is. I think this is an ongoing debate that needs to have a bit of context, really. I mean, firstly, social prescribing isn't a paternalistic pursuit. I mean, I say it's not signposting. This isn't what I call paternalistic pointing, where a clinician just says you need to go and learn how to dance, or you need to go and do some walking football. This is about a truly level conversation, a meeting of equals, starting with that. What matters to you point that I made. When done well, social prescribing is about tapping into what matters to that individual, and it's led by them. The term social prescribing has just stuck. It's ended up being what we call the process. It also, in many circumstances, works with having that trusted role within the community. We've all mentioned that 1 in 5, maybe, as much as 30–40% of people go to see their GP for a non-medical reason. They're going to see their GP because that person is working in an anchor institution and is a trusted part of their community, and they're reaching out for support. So actually, it's important for that individual to have that conversation with the GP and then the link worker. But I don't see it as a power differential. I see the term just being the name. A rose by any other name would smell as sweet. If you look at that, I think it's just the name, not what it's doing.
Lovely, thanks. Another really interesting question, I think, from Kathy Vaughan. Great to hear about the valuing of concrete practical skills such as community organising, engagement, working with diverse people, in addition to being fundamental to many of the allied health disciplines. We've had a couple of very interesting comments from occupational therapists in particular who said, look, we've been at this for a long, long time. Please listen to us, which is an interesting point. Kathy asked, are these skills, saying these skills ones that all public health graduates need. So we're very interested in this. How is this being incorporated into public health training in the UK?
I love occupational therapists. Shall I just start there? I mean, occupational therapists have got huge amount of skill and knowledge in this area, and are fundamental to the way in which social prescribing is implemented. We've worked extensively with occupational therapists to build the model alongside social workers as well, local area coordinators, community developers. You know, all of the people that are working in this area have a massive role to play, and worked extensively with the Royal College of OTs over here in England to map where social prescribing and occupational therapy fit together. It's a real complementary pursuit, and we're massive champions within our group of occupational therapists. And actually, the head of social prescribing for England is herself an occupational therapist. So I really agree with those skills. In terms of how we embed it, that's where the Personalised Care Institute comes in. We are embedding this into clinical training. We're putting it into undergraduate training for GPs and for nurses. We've got extensive leadership programs that have embedded personalised care into that practice now. And over the next couple of years, we're going to train 75,000 practicing clinicians in personalised care techniques, sort of deep training in that, and aiming for 300,000 clinicians being trained by 2024. So huge ambitions there, because we recognise that this is a new technique and that people do not necessarily learn in medical school and in other aspects of their training. So we really need to embed that.
Lovely, thanks, James. Look, we're meant to be wrapping up now. We might go on for another 10 minutes, if that's okay. So I'll keep asking questions of the panel. And one here, which is from Mariam Hutcham: how do we navigate patient activation or making the patient the expert in their condition for people with mental health conditions and related comorbidities? Do you have an example of how this might have worked?
So for me as well, that's a tough question. I think you know, in relation to patient activation measurement, it has mainly been trialled in relation to physical conditions rather than mental health. And increasingly, we're starting to see people use health coaching as a technique for people that are facing mental health issues, and that's proving to be really important. You know, the general premise of building an individual's skills, knowledge and confidence, regardless of whether it's mental or physical health, is having an impact in terms of outcomes. And we're seeing, you know, the reason that we say that this is a comprehensive model for personalised care is that it's not just one of those boxes in that 6 diagram model I showed you. It's all of them working together. So somebody may require health coaching for their mental health, they may require patient activation measurements, they may require peer support, they may need a social prescription to connect them to local groups, they may need the resources to structure care in a particular way that's suitable for them. So, you know, sometimes a very, very complex approach is needed. And I think when we're combining issues of mental and physical health with comorbidities, it's where that the need for that whole model comes in, so that you can provide a package of support that's truly going to meet their needs of the individual.
Great, thanks, James. Just a comment here from Adeline Kwan in Singapore, saying that they're implementing social prescribing at the secondary care setting in Singapore. It's 3 public hospitals. They're very keen on patient activation measurements as an outcome, and we certainly look forward to engaging insights on this and looking forward to being in touch. And the email is there for everybody to see. So thank you very much indeed. I guess this is for Megan and for Tracy. Is how do you line up the funding across different silos of government outside the healthcare system, for example, employment and housing?
I wish there was an easy answer to that, would be the simple response. I think the reason that people think I'm paid big bucks is because my job is to go out and hunt those dollars and try and form those partnerships and make it work. And it is a labour of love, and it does require ongoing diligence, because finding the money and justifying it in the long term is incredibly time intensive, which is why I would much prefer that there was a national system, so that chasing money isn't the game. Delivering real care and better services becomes our ultimate objective.
Right, lovely, thank you very much. Also, just, I mean, this is a very broad question from Hemraj Pandey about what do you think about implementing social prescribing in developing countries as people are lacking even basic education, health systems not well established, mushrooming private hospitals, and maybe not such good governance. Anybody want to have a crack at that one? James, you might want to.
I do some work in the Philippines, and I'm completely struck by the fact that, I mean, they have so little that just having basic stuff, the work we do that has the biggest impact is all around what we call social prescribing. And it's about the empowerment to, what's it saying, the words of, if you give them a fish hook, then they can go out and learn how to fish. And it's around that same thing about giving people the skills to know how to help make their life better, actually improves health considerably, and is extraordinarily powerful. So go for it is all I can say, because you're going to have far more impact. My husband is a structural engineer, and can I tell you, he tells me all the time that a structural engineer has more impact on improving health than I do as a doctor, and I get it in terms of those big public health things that structural engineers need to do. And we need to remember that when we're putting out health projects, particularly in those sort of developing countries. But Australia's the same. I mean, we need to remember we don't have the basic foundations right. What's the point in pouring in an expensive medicine? Let's get our priorities really fixed on improving the quality of life of Australians, and if we can do that and empower them in knowing how to do things, well, how to find things and actually make health choices better, then a whole lot of things will improve. And let's communicate better.
Thanks. And a comment here from Melanie Tyre about the fact that there are 400 neighbourhood houses in Victoria, and we have more neighbourhood houses than McDonald's in Australia, my goodness. Picking up on Charlotte's points about referral pathways, how do we get our services activities in front of GPs? What's the best format for us to give you our information? Great point.
Are you okay if I sort of go on that, the referral? I mean, in New South Wales, one of the biggest things we've been trying to do is work with a thing called Health Pathways, and it is an Australia-wide process, but really from where I sit, it's one of the most powerful ways of getting that in there. To do that, though, takes those conversations between all parties and upskilling GPs to know where to go, and it's like anything. As you build the number of pathways that people can go and find out about, then it gets better and better, but it needs the investment in terms of keeping on top of it all the time. It's like what Megan was talking about, her project is so powerful, but there's a huge amount of work in actually making sure that everything is up to date and ongoing, and it's no point in putting something up that you then go and access and it's all gone, which means then I'm not going to go back there and look to find the services again next time. So we do need to make sure that the investment we put into those referral pathway systems, which are fantastic, have to have that amount of investment and keep it going. But I can't speak more highly about health pathways, and what we're really trying to do in New South, well, from where I've been sitting, is about making sure that allied health referral pathways are embedded in that, as well as not just the hospital and medicalised ones, and then for the patients to understand where they can go as well, so that it's a very sort of bigger, richer picture of referrals.
Lovely, thanks. Just the last comment, and then I'll come back to we'll put up the slide about where we're going. Just to note, the Australian government, this is from Andrew Clark, is currently funding a national navigator pilot with 64 trial sites across Australia to assist older people to understand and gain access to aged care services. The trial includes services to culturally and linguistically diverse and Indigenous communities. So thanks. and which sort of raises the point of where to next, not only in future events, but the question of, well, the notion of a national model, to learn from the UK experience. And James, I'm sure we will be coming back to you for your input into this. But just to say that I want to thank Sian for really conceptualising this whole idea of this particular webinar, and support the work that's already been done by so many people across Australia. How can we build this? How can we make the bold move? What the bold move is, but I would beseech of you all to be involved in that and to work out how we can get a strong, collective, united initiative going. Just as it happens here's some webinars, October, November, February, or a series of online webinars around social prescribing, socialisation, social prescribing, social isolation, and run by the Australian Disease Management Association, the Melbourne Academic Centre for Health, Monash Partners, and the Western Alliance. So please have a look at those if you can. If anybody has any question or wants to get in contact with us, please do so at the following email. It's hello at mpghss.org.au. So hello at mpghss.org.au, which is the Students Association. And on that note, I wanted to thank all of thank you, the audience that is still there. There's still almost 200 of you. We're incredibly grateful that you've enjoyed this session with us. I'm sorry we couldn't get to all your questions, but I just wanted to thank, on your behalf, to thank the panelists, to thank James Sanderson, to thank Nancy for opening the session, to thank Charlotte Hesby, Sandro De Meo from Vic Health, Tracy Johnson, Megan Cicciarelli, and Leanne, thank you very much for wrapping it up, and just to again congratulate you for the work that you're doing with the Consumer Health Forum, and to say we want to support these collective efforts in the future. So, and again, thank you to Sian and to Zainab and Julia Nonifor and for helping us out. So thank you very much indeed. And we look forward to seeing you in the future. Thank you.